Welcome to this tutorial on disorders associated with acid-base balance, brought to you by Medical Biochemistry Power Capsule Series. This video covers the following CBME curriculum topics: describe the processes involved in maintenance of normal pH, water and electrolyte balance of body fluids, and the derangements associated with these. Discuss and interpret results of arterial blood gas analysis in various disorders. We strongly suggest that you should go through tutorial 6b, which is available in this series, before you watch this video. Many pathological conditions are accompanied by acid-base and electrolyte disturbances. Abnormalities in acid-base status of the body are generally accompanied by characteristic changes in electrolyte concentrations in the plasma. Acid-base disturbances are critical because they reflect and impact the body's ability to maintain a stable internal environment. Identifying the type and cause of acid-base disturbance helps diagnose underlying medical conditions and guides medical intervention. Acid-base status can also offer prognostic information. The main categories of disorders related to acid-base homeostasis include metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Generally speaking, acidosis occurs as a result of one or a combination of three mechanisms: increased addition into the body system or endogenous synthesis of acid, decreased elimination of acid, and increased loss of base. Similarly, alkalosis occurs as a result of one or a combination of three mechanisms: increased addition of base into the body system or increased synthesis of base, decreased elimination of base, and increased loss of acid. What is metabolic acidosis, and what happens in metabolic acidosis? Metabolic acidosis is also known as primary alkali deficit. It is the commonest disturbance of acid-base balance observed clinically. It is caused when there is a reduction in the plasma bicarbonate concentration, with no change or little change in the carbonic acid fraction. If primary deficit of bicarbonate occurs, the ratio bicarbonate divided by carbonic acid decreases. As per the Henderson-Hasselbalch equation, the pH then decreases, resulting in metabolic acidosis characterized by primary bicarbonate deficit. Let's review the Henderson-Hasselbalch equation. Here pK is a constant, base within brackets is concentration of base, and acid within brackets is concentration of acid. The equation basically means that pH of a solution or fluid is dependent on the ratio of the concentration of basic ion and its conjugate acid. Recall that every acid has its conjugate base, which is the anion part of the acid molecule. So acids and bases exist as conjugate pairs. Metabolic acidosis, when it occurs, has to be corrected through compensatory mechanisms. Reasons have already been discussed in the previous tutorial. The primary compensatory mechanism in metabolic acidosis is through the respiratory center. The respiratory center is stimulated by acidosis, causing deep and rapid breathing. This increased ventilation will result in loss of carbon dioxide and reduction in carbonic acid. As a result, the ratio of bicarbonate-carbonic acid is restored towards normal. As levels of both in blood get reduced, however, respiratory compensation is only partial because two opposing forces are at work. While acidosis stimulates respiratory center, causing reduction in partial pressure of carbon dioxide, the resulting low partial pressure of carbon dioxide depresses the respiratory center. Hence, respiratory compensation becomes ineffective after some time. Therefore, only this respiratory mechanism is not be sufficient to compensate the acidosis. Please follow the flowchart shown here. During the early stages, alkali deficit takes place due to various reasons. But compensatory mechanisms are working too. Hence, the body is in a state of compensated acidosis. But as the condition progresses and if treatment and management is not instituted, the alkali deficit becomes more pronounced and the primary compensatory mechanism fails. The condition then progresses to uncompensated acidosis. The hydrogen ion concentration in blood starts increasing because sufficient buffer is no longer available for neutralizing the hydrogen ions. It is the state of uncompensated acidosis. Left untreated, the patient may not survive. In uncompensated metabolic acidosis, there will be a disproportionate decrease in bicarbonate ion concentration. There will also be decrease in carbonic acid due to elimination through lungs and decrease in partial pressure of carbon dioxide. There will also be a decrease in total carbon dioxide content, decrease in bicarbonate carbonic acid ratio, and decrease in pH. Note that, though the carbon dioxide decreases, the bicarbonate concentration decreases more ultimately. It's all a matter of the base by acid ratio. In this situation here, the base divided by acid factor decreases, leading to a lower pH value. This means that acidity increases. Secondary compensatory mechanism, involving renal mechanisms, attempts to correct the disturbances in metabolic acidosis by various means. These mechanisms include conservation of cations, increased ammonia formation, increased hydrogen ion excretion compared to potassium ion excretion in distal tubule, and by reabsorption of bicarbonate ion. In fully compensated metabolic acidosis, carbon dioxide content is low, bicarbonate concentration is also low. However, the decrease in bicarbonate and carbonic acid is proportionate, and bicarbonate carbonic acid ratio remains within normal limits. Therefore, the pH will also be within normal limits in fully compensated acidosis. As mentioned earlier, acidosis can occur due to increased acid production. Lactic acidosis occurs when there is increased production of lactic acid due to inadequate oxygen delivery or utilization. It can be caused by conditions like shock, sepsis, severe anemia, heart failure, or intense exercise. Ketoacidosis is commonly seen in diabetes mellitus, which is known as diabetic ketoacidosis. This occurs when there's a lack of insulin, leading to increased ketone body production from fatty acid breakdown. Ketoacidosis can also occur with alcoholism or starvation. Ingestion of exogenous acids can cause acidosis. Substances like methanol, ethylene glycol, or salicylates can metabolize into acids, thereby causing metabolic acidosis. Decreased acid excretion can be a reason for acidosis. Renal failure and renal tubular acidosis are notable examples. The kidneys play a crucial role in maintaining acid-base balance by excreting acids and reabsorbing bicarbonate. In chronic kidney disease or acute renal failure, this ability is compromised, leading to an accumulation of acids in the blood. Renal tubular acidosis is a condition which occurs when there is a defect in the renal tubules, impairing acid secretion or bicarbonate reabsorption. Renal tubular acidosis can be primary or secondary to other diseases, such as autoimmune disorders or due to intake of certain medications. Loss of bicarbonate is an important cause of metabolic acidosis. This may happen in diarrhea, intestinal pathology, certain surgical procedures like ileostomy, and due to renal losses. The gastrointestinal tract is a significant source of bicarbonate. Conditions causing chronic diarrhea can lead to a substantial loss of bicarbonate, resulting in metabolic acidosis. Intestinal fistulas or ileostomies can lead to excessive loss of bicarbonate. Similar to diarrhea, renal loss of bicarbonate may occur. Conditions like proximal renal tubular acidosis cause the kidneys to lose bicarbonate, leading to a drop in blood bicarbonate levels. Before proceeding further, an idea about anion gap is necessary. Body fluids, including plasma, are electrically neutral. This means that anion and cation concentrations are balanced. But if the sum of chloride and bicarbonate values is subtracted from the sum of sodium and potassium, the difference, or gap, averages 10 to 14 millimoles per liter in healthy subjects. This apparent gap is due to unmeasured anions, such as proteins, sulfate, phosphate and organic acids that are present in plasma. This difference is known as anion gap. Go through the gambogram given alongside. While the total value of cations and anions are equivalent, there is a gap due to unmeasured anions. Had those anions also been measured and taken into consideration in laboratory analysis, then there wouldn't have arisen any need to coin such a term as anion gap. Hence anion gap is nothing special, but simply reflects the fact that, conventionally, we don't measure some anions while estimating serum electrolytes. You will notice that the anion gap will increase if either chloride or bicarbonate ion concentration, individually or both together, decreases. Anion gap may also decrease. This may occur due to laboratory measurement errors, intoxication by ions, such as lithium, bromide, and iodide, decreased albumin concentration, increased immunoglobulins, etc. Anion gap is an useful parameter when it comes to diagnosing the underlying cause of acid-base disorder. In metabolic acidosis, the value of anion gap depends on the actual cause of acidosis. What are the causes of increased anion gap? Let's find out. Unmeasured plasma anions increase with or without changes in sodium and chloride in metabolic acidosis associated with uremic acidosis, lactic acidosis, diabetic ketoacidosis, salicylate overdose, methanol ingestion, etc. Increase in plasma sodium concentration due to high input of sodium salts can result in a high anion gap. High anion gap may also be an artifact due to improper handling of specimens causing loss of carbon dioxide, or due to analytical errors. Now, let's see what respiratory acidosis is. Respiratory acidosis is also called primary carbonic acid excess. The underlying abnormality here is increasing carbonic acid content in the blood, which is due to decreased elimination of carbon dioxide through the pulmonary alveoli. This may result from breathing air containing abnormally high percentage of carbon dioxide, and also in conditions where elimination of carbon dioxide through lungs is hampered. Mechanism of development of respiratory acidosis is as follows. If excretion of carbon dioxide through lungs is impaired, as in case of emphysema, respiratory infections, or depression of respiratory center, more carbon dioxide will accumulate in blood, resulting in formation of excess carbonic acid. This results in lowering of the bicarbonate-carbonic acid ratio, therefore, the pH decreases. As expected, the respiratory mechanism tries to compensate. Increased stimulation to respiratory center due to increased partial pressure of carbon dioxide results in increased depth and rate of respiration with consequent increase in ventilation. However, this mechanism usually loses its importance, as the defect may lie with the respiratory center itself, or some serious pathology in the lungs. As a result, this compensatory mechanism becomes less effective and insufficient to correct the imbalance. Renal mechanism is of prime importance for compensating respiratory acidosis. When respiratory acidosis occurs, more bicarbonate ions are reabsorbed from renal tubules in response to raised carbon dioxide in blood. As a result, the bicarbonate-carbonic acid ratio gets restored. Though phosphate and ammonia buffering continues to occur in kidneys, reabsorption of bicarbonate ions takes precedence. Uncompensated respiratory acidosis is characterized by a disproportionate increase in carbonic acid and partial pressure of carbon dioxide. Interestingly, concentration of bicarbonate ion also increases, but is not sufficient to counter the acidosis. There is increase in total carbon dioxide content, decrease in bicarbonate-carbonic acid ratio, and decrease in pH. On the other hand, fully compensated respiratory acidosis is characterized by high total carbon dioxide, but increase in carbonic acid and bicarbonate is proportionate. Therefore, the bicarbonate-carbonic acid ratio as well as the pH remain within normal limits. Let's explore some of the factors that are responsible for respiratory acidosis. Central nervous system depression is a cause. Sedative or narcotic overdose can cause respiratory acidosis. Drugs like opioids, benzodiazepines, or barbiturates can depress the respiratory center in the brain, leading to decreased respiratory drive. This causes hypoventilation, leading to carbon dioxide retention and respiratory acidosis. Brain injury or stroke can be a cause. Damage to the brain's respiratory centers, such as from a stroke, trauma, or hemorrhage, can impair the ability to control breathing, resulting in respiratory acidosis. Respiratory muscle disorders can also cause respiratory acidosis. Neuromuscular diseases like myasthenia gravis, Guillain-Barré syndrome, or amyotrophic lateral sclerosis can weaken the respiratory muscles, making it difficult to maintain adequate ventilation. This leads to hyperventilation and respiratory acidosis. Severe fatigue or injury, or severe muscle fatigue from prolonged respiratory effort such as in severe asthma or COPD exacerbations, can lead to reduced ventilation and therefore cause respiratory acidosis. Airway obstruction can be a cause. Severe exacerbations of asthma or chronic obstructive pulmonary disease can lead to airway constriction, mucus plugging, or increased airway resistance, causing hyperventilation and carbon dioxide retention, ultimately resulting in respiratory acidosis. Obstructive sleep apnea can also cause respiratory acidosis in extreme situations. Repeated episodes of upper airway obstruction during sleep lead to periods of hyperventilation, thereby contributing to respiratory acidosis. Lung disorders, such as pulmonary edema and pneumonia, can impair gas exchange by filling the alveoli with fluid or inflammatory exudates, leading to reduced ventilation and consequent carbon dioxide retention, causing respiratory acidosis. Severe atelectasis, which is collapse of lung tissue, can reduce the effective surface area for gas exchange, leading to hyperventilation and respiratory acidosis. Chest wall disorders can cause chronic respiratory acidosis. Severe deformities of the spine and chest wall, as in kyphoscoliosis, can restrict lung expansion, leading to reduced ventilation and respiratory acidosis. Traumatic injuries such as fractures of the ribs or sternum, or other chest wall injuries, can impair respiratory mechanics, leading to hyperventilation, which ultimately causes respiratory acidosis. Now, let's see what metabolic alkalosis is all about. Metabolic alkalosis is also known as primary alkali excess. This condition results from an absolute or relative increase in bicarbonate. Primary alkali excess or increase in the alkali reserve is the most frequent cause of clinically observed alkalosis. Excess of bicarbonate accumulation, often due to soluble alkali ingestion, causes an increase in the bicarbonate-carbonic acid ratio. Therefore, the pH increases due to a relative deficit of carbonic acid in blood. The respiratory center is inhibited by alkalosis, causing shallow, irregular breathing. As a compensatory mechanism, this reduced ventilation will result in carbon dioxide retention and increase in carbonic acid level. The bicarbonate-carbonic acid ratio then tends to be restored towards normalcy as the levels of both in blood are increased. However, decreased ventilation has a tendency to raise the partial pressure of carbon dioxide in blood, which tends to stimulate the respiratory center. This stimulation results in the elimination of carbon dioxide through lungs, therefore taking the situation back to square one. Hence, two opposing forces are working in tandem. The alkalosis depresses the respiratory center, while carbon dioxide stimulates the respiratory center. As a result, respiratory compensation is insufficient and renal compensation becomes essential. Renal compensatory mechanisms operate in metabolic alkalosis. Hereby, the excretion of bicarbonate, by replacing chloride ions in urine, is augmented. Both are due to a decrease in sodium-hydrogen exchange. Potassium excretion increases in the distal tubules instead of hydrogen excretion. There is reduced ammonia formation and reduced excretion of non-volatile acids, such as lactic acid and ketoacids. In short, acids are conserved by kidneys. Loss of gastric acid through vomiting and nasogastric suction can be a cause of metabolic alkalosis. Gastric secretions contain high concentrations of hydrochloric acid. Repeated vomiting or prolonged nasogastric suction removes this acid from the body, leading to a reduction in hydrogen ions and an increase in bicarbonate relative to acid. This shift in acid-base balance results in metabolic alkalosis. Use of thiazide and loop diuretics may result in metabolic alkalosis. These medications increase renal excretion of sodium and chloride, creating a state of relative volume depletion. The kidneys respond by increasing the reabsorption of sodium in exchange for hydrogen and potassium ions. This process leads to an increased retention of bicarbonate, contributing to metabolic alkalosis. Please recall the renal mechanism described earlier in the tutorial on acid-base balance. Primary hyperaldosteronism involves excessive production of aldosterone, a hormone that promotes sodium reabsorption and potassium and hydrogen excretion in the kidneys. The increased loss of hydrogen ions leads to a rise in bicarbonate levels, causing metabolic alkalosis. Secondary hyperaldosteronism condition is caused when reduced renal perfusion, such as in heart failure or renal artery stenosis, leads to increased renin production, stimulating aldosterone secretion in the process. This too contributes to metabolic alkalosis through similar mechanisms. Metabolic alkalosis can develop in diseases in which endogenous mineralocorticoid, glucocorticoids, or both, are elevated. Such diseases include primary and secondary hyperaldosteronism, bilateral adrenal hyperplasia, pituitary adrenocorticotropic hormone-producing adenoma as in Cushing disease, and primary adrenal adenomas producing glucocorticoids or aldosterone. Elevated levels of mineralocorticoid and glucocorticoids can lead to metabolic alkalosis. In states of adrenocortical excess, potassium and hydrogen ions are wasted by the kidneys as a consequence of increased sodium reabsorption stimulated by elevated aldosterone or cortisol. The attendant hypokalemia often further contributes to the alkalosis, and this should be treated with potassium replacement therapy. Hypokalemia is a common feature of metabolic alkalosis. Administering potassium to the patient is an important part of treatment protocol. Ingestion of alkaline substances can lead to metabolic alkalosis. However, this can happen only if the consumption has been excessively high. Overconsumption of bicarbonate-containing antacids or other alkaline substances can directly raise blood bicarbonate levels, leading to metabolic alkalosis. Milk alkali syndrome is a condition which occurs when there is an excessive intake of calcium and absorbable alkali, leading to an increase in bicarbonate and a decrease in hydrogen ions. Other causes of metabolic alkalosis include hypokalemia and contraction alkalosis. It's interesting to note that hypokalemia is a consequence of alkalosis as well as a cause of metabolic alkalosis. In a situation of hypokalemia, the low level of potassium in the blood can cause an intracellular shift of hydrogen ions, leading to a decrease in extracellular hydrogen ions and resulting in increased bicarbonate levels. Contraction alkalosis is a form of metabolic alkalosis that results from the loss of fluid volume without a corresponding loss of bicarbonate. It can occur with dehydration or excessive diuresis, where the reduction in plasma volume leads to a relative increase in bicarbonate. Depending on how chloride ions are handled by the body, metabolic alkalosis can be of two types: chloride-resistant and chloride-responsive. Chloride-resistant metabolic alkalosis is almost always associated with an underlying disease, such as primary hyperaldosteronism, Cushing's syndrome, or Bartter syndrome. In these conditions, urine chloride concentration will usually be greater than 20 millimoles per liter. It is far less common than chloride-responsive metabolic alkalosis. Chloride-responsive metabolic alkalosis can occur due to prolonged vomiting, nasogastric suction, and upper gastrointestinal tract obstruction. In these conditions, urine chloride will usually be less than 20 millimoles per liter. Well, let's now dive into respiratory alkalosis. Respiratory alkalosis is caused by a decrease in carbon dioxide concentration in blood and the resulting primary deficit in carbonic acid caused by an increased rate and/or depth of respiration. Therefore, the basic cause of respiratory alkalosis is excess elimination of acid via the respiratory route. Excessive elimination of carbon dioxide reduces the partial pressure of carbon dioxide and causes an increase in the bicarbonate-carbonic acid ratio. The latter shifts the normal equilibrium of the bicarbonate-carbonic acid buffer system, reducing the hydrogen ion concentration and increasing the pH. Though the total bicarbonate concentration may also be low, yet, in uncompensated respiratory alkalosis, the overall value of the ratio increases due to disproportionate loss of carbon dioxide. Psychogenic causes, such as anxiety or panic disorders and emotional distress, can be a reason. High stress levels, panic attacks, or anxiety can lead to rapid breathing or hyperventilation, causing excessive elimination of carbon dioxide. This results in respiratory alkalosis. Conditions involving intense emotional stress or excitement can similarly trigger hyperventilation and result in respiratory alkalosis. Hypoxemia is also a cause. At high altitudes, reduced oxygen availability stimulates the respiratory center, leading to increased ventilation as the body attempts to compensate for lower oxygen levels. This results in respiratory alkalosis due to excessive carbon dioxide loss. Pulmonary disorders and conditions like pulmonary embolism or pulmonary edema can lead to hypoxemia, which stimulates hyperventilation as a compensatory mechanism, ultimately causing respiratory alkalosis. Central nervous system stimulation may occur in certain infections, or injury, or in fever. This may cause respiratory alkalosis through stimulation of respirator center. Infection or injury. Conditions affecting the central nervous system, such as meningitis, encephalitis, or brain trauma, can lead to heightened stimulation of the respiratory center, resulting in hyperventilation and respiratory alkalosis. Fever, elevated body temperature, can increase metabolic rate and stimulate the respiratory center, leading to hyperventilation and respiratory alkalosis. High levels of salicylates like aspirin can directly stimulate the respiratory center, leading to hyperventilation and respiratory alkalosis in the initial stages. Stimulant substances like caffeine, amphetamines, or cocaine can increase respiratory rate, resulting in respiratory alkalosis in patients receiving mechanical ventilation if the ventilator settings are too high or if the patient hyperventilates. This can lead to excessive removal of carbon dioxide and thereby cause respiratory alkalosis. It's important to remember that though salicylates may cause respiratory alkalosis in the initial stages of poisoning, the condition soon converts to metabolic acidosis due to high levels of exogenous acid. Compensatory mechanisms for respiratory alkalosis respond in two stages. In the first stage, erythrocyte and tissue buffers provide hydrogen ions that consume a small amount of bicarbonate ions. The second stage becomes operational in prolonged respiratory alkalosis and depends on renal compensation as described for metabolic alkalosis, and involves such mechanisms like decreasing the reclamation of bicarbonate ions. Acid-base disorders have significant implications for electrolyte balance, mainly affecting potassium, calcium, chloride, and phosphate levels. These imbalances can lead to various clinical manifestations, requiring careful management and treatment based on the underlying cause. Please pause here and go through the table depicting the normal serum levels of the important electrolytes including sodium, potassium, ionized calcium, chloride, phosphorus and magnesium. These are numerical values which you cannot afford to forget and need to remember throughout your professional career. Electrolyte profile in metabolic acidosis includes hyperkalemia, high levels of ionized calcium in blood, and hyperchloremia. Metabolic acidosis is often associated with hyperkalemia, that is, elevated potassium levels. This occurs because hydrogen ions move into cells in exchange for potassium ions, leading to increased extracellular potassium. In renal failure, the inability of the kidneys to excrete potassium exacerbates this condition. Calcium disturbances can occur. Acidosis can lead to increased ionized calcium in the blood. The lower pH reduces calcium's binding to albumin, thus raising the levels of free or ionized calcium, which can lead to neuromuscular depression or arrhythmias. Chloride disturbances may also occur. Some forms of metabolic acidosis, like normal anion gap acidosis, are associated with hyperchloremia, which is a condition of increased chloride concentration in blood. This occurs due to bicarbonate loss, as in diarrhea, with chloride ions replacing bicarbonate to maintain electrical neutrality. What's the electrolyte profile in respiratory acidosis like? Well, there may be derangements in potassium and calcium levels in blood. Hypercapnia and the consequent increase in hydrogen ion concentration in blood can lead to hyperkalemia, similar to metabolic acidosis, as cells exchange hydrogen ions for potassium ions, raising extracellular potassium. Respiratory acidosis can also increase ionized calcium due to a decrease in calcium binding to albumin, similar to metabolic acidosis. And what happens in metabolic alkalosis? A disturbance in potassium concentration is usually common. Metabolic alkalosis is commonly associated with hypokalemia. This happens as potassium ions move into cells to balance the decrease in hydrogen ions because hydrogen ions move into extracellular fluid. In conditions like vomiting or diuretic use, potassium is lost, further contributing to hypokalemia. Calcium disturbances can also occur. Alkalosis can lead to decreased ionized calcium levels due to increased binding of calcium to albumin. This is just the reverse of what happens in acidosis. This reduction in ionized calcium can cause neuromuscular excitability, leading to symptoms like muscle cramps, tetany, or seizures. Metabolic alkalosis often leads to hypochloremia, particularly when caused by vomiting or diuretic use. The loss of gastric hydrochloric acid or increased renal excretion of chloride leads to low chloride levels. And lastly, what's the electrolyte profile in respiratory alkalosis? Well, derangements of potassium, calcium, and phosphate concentrations may be noticed. As in metabolic alkalosis, respiratory alkalosis can cause hypokalemia, as potassium moves into cells due to a decrease in extracellular hydrogen ions. Calcium disturbances are due to similar reasons as mentioned previously while discussing metabolic alkalosis. Phosphate disturbances may occur. Respiratory alkalosis can lead to hyperphosphatemia, as high intracellular pH promotes phosphate uptake into cells, thereby decreasing the extracellular phosphate concentration. Arterial blood gas analysis is a diagnostic tool used to assess the acid-base balance, oxygenation, and ventilation status in a patient. It provides information about the levels of oxygen, carbon dioxide, and pH in arterial blood, helping clinicians determine respiratory function and metabolic status. Meaningful acid-base studies on blood usually require arterial specimens, and samples need to be analyzed soon after collection. An ABG analysis typically includes the following measurements. pH indicates the acidity or alkalinity of the blood. The normal range is 7.35 to 7.45. PaCO2 is the shortened form of partial pressure of carbon dioxide in blood. The partial pressure of carbon dioxide in arterial blood reflects the respiratory component. The normal range is 35 to 45 millimeters of mercury. PaO2 is the partial pressure of oxygen in arterial blood, reflecting the oxygenation status. The normal range is 85 to 100 standard units. Bicarbonate concentration indicates the metabolic component of acid-base balance. The normal range is 20 to 26 milliequivalent per liter. SaO2 is the shortened form of oxygen saturation. It is the percentage of hemoglobin saturated with oxygen. The normal range is 95% to 100%. Interesting to note that the COVID pandemic has made this term quite popular even among the non-medical population. Please pause here for a couple of minutes and go through this table. The various important parameters in the different types of acid-base homeostasis disorders have been depicted. Please understand that this table depicts a generalized situation in relation to the four principal disorders. However, the actual picture may vary depending on the stage of compensation and presence of other comorbidities. Furthermore, it's important to understand that very often, mixed disorders may be present in the clinical setting, and depending on the actual pathological condition that has contributed to acid-base homeostasis disorder, the patient may shift from one kind of disorder to another. Thus, metabolic acidosis may overlap with respiratory acidosis if lactic acidosis, due to shock, is present along with concomitant pulmonary disease.
Thanks for watching this video. Our next tutorial in the Medical Biochemistry Power Capsule series is titled Xenobiotics. The tutorials presented in the MBPC series are not intended to be a substitute for your textbooks. However, we feel that these tutorials can prove to be very valuable as complementary educational aids and for purpose of rapid revision prior to exams. If you have enjoyed this video, don't forget to hit the like button, subscribe for more exciting content, and share with your friends. And do keep watching our channel to remain ahead in the game.